Well, good morning, good afternoon, good evening. We're coming from across the globe, so of course we're covering all time zones. This is another episode of Beyond the Headlines, and I am thrilled today to be introducing two guests, Dr. Peter van Dedelzen, who is a professor of global health at King's College in London, and Dr. Rahat Qureshi, who comes to us from Aga Khan University in Pakistan. And they are both investigators, principal investigators on a recent study that came out in the Lancet called offering the results, a sort of another take on the results of the CLIP trial. So that's really what we're going to be talking about today is the community level interventions for preeclampsia. We are going to be focusing on global health, and really the reason we're talking about this, the Preeclampsia Foundation, is because we were involved in not just this study, but this whole package of projects under the moniker Preempt, which was funded by the Bill and Melinda Gates Foundation. We were involved for over 7 years, and one of the important contributions of this study, in some ways a minor aspect of what was actually being studied, but an important aspect of what was discussed as important, was knowledge translation. And that is taking the results of not just this work, but other work, and really trying to bring it take it outside the bubble of the research community to the masses. Because if research doesn't find its way to actual clinical care, then one might ask, why are we doing it? So the Preeclampsia Foundation is very focused and dedicated on communications and bringing this to not just the patient community, but to the larger community where advocacy and advocates can make a difference in bringing this information out. So let's go ahead and jump right in. I am going to, as I mentioned, Dr. Van Dedelzen and Dr. Qureshi were principal investigators. Dr. Van Dedelzen really was the mastermind behind all of this. So I'm going to ask you, Dr. Van Dedelzen, to take us back to 2010, when $7 million was provided by the Gates Foundation to when this project was first announced. What prompted your journey into global health? Because you haven't always been in that space.
No, thanks, Eleni. I mean, and thanks for the privilege of being part of this discussion. I became interested in preeclampsia as a very early trainee in New Zealand, where I'm originally from. A particular woman who was particularly unwell spectacularly quickly in front of my eyes made me wonder what had happened to her. And for the next probably 10, 15 years, I spent much of my research career as I was training to be an obstetrician, trying to understand what had happened in the setting of more developed countries like New Zealand, the UK, and Canada, which are the three places I've trained and practiced. And what happened is somewhere along the journey, I suddenly realized that I was really just working in a very small corner of where women were at risk, because 99% of maternal mortality, 99% of stillbirths, and 99% of neonatal deaths occur in less developed countries such as Pakistan, India, Mozambique, which is where we did the CLIP trials. So I suppose I pivoted towards being more interested in global health because I recognized that's where I, as an academic, could have the greatest impact.
And subsequent to the initial announcement, the Gates Foundation eventually contributed considerably more millions of dollars to this project and to the whole program, the Preempt program. And the CLIP trial, Community Level Intervention Program, underwent a number of revisions. What did you ultimately set out to prove with the CLIP trial? What was the original intention there?
Yeah, so to a certain extent, we were given firm guidance by the foundation, the Gates Foundation, not the Preeclampsia Foundation, on which direction to travel, which was to look at the community. because before that, most intervention studies had occurred in hospitals, and they had been almost uniformly focused on magnesium sulfate. And it was sort of a reductionist view. If we could get magnesium sulfate used in hospitals, we would solve the problem. And although magnesium sulfate's important, it isn't the whole story. So the Gates Foundation said, well, that hasn't been that effective. So let's look at the other end of the spectrum and see how we can work with communities. And part of that was knowledge translation into communities, asking, you're advising women about birth preparedness, telling them about pregnancy complications, including hypertension. You're working out how to put together a bundle of evidence-based components. So everything had been tested within the bundle previously, but bundling it together and asking community health workers to provide that knowledge translation to families and provide antenatal care and initiate care in hypertensive women in women's homes. That was the underlying premise. But where it started and where it ended up, we ended up being really very different because of interactions with the sites. We spent a year doing feasibility work in each of the countries to understand how to make, hopefully to make the program successful.
So let's talk about one of those countries, because the interventions, the trial ultimately was done in Mozambique, India, and Pakistan. And Dr. Qureshi, you are with us today to talk about your experience in doing this in Pakistan. What inspired you to, what about this particular project inspired you to join as one of the main study sites?
Thank you very much, Eleni, for this opportunity to talk about our contribution in Pakistan to this amazing global health venture. So I think I've been working in Pakistan for a long time in academic settings. And this opportunity, this CLIP opportunity actually gave us the arena of public health to go out into the community and start working with patients in the community to see how well we could actually bring in certain interventions, design certain interventions which could actually work in the community setting. So this, for us, this has been an amazing experience, because so far in Pakistan, and I think in many countries of the world, in low and middle income countries, many interventions which come in, and many medical evidence-based interventions which come in to improve women's health, stay in hospitals and academic facilities or large hospitals. They do not really reach out to women in the community. And it's rather unfortunate that many women who are delivering and who are having babies in the community. And so really there is a gap, there's a distance and there's a gap between what is available, what can help them, and what actually reaches them. So the CLIP trial gave us the opportunity to actually take the package into the community and provide it in the community to see how best it would work. That was, for me, beyond the statistics and beyond the working out of the outcomes based on intervention and based on controls, was reaching out and seeing how well we could actually introduce that package into the community.
Tell us a little bit about the problem of preeclampsia in Pakistan. How would you characterize the issue of preeclampsia and in Pakistan?
So I think one of the most basic requirements for meeting any kind of challenge for pregnant women, which is a challenge which is going to affect the health of the woman, the health of the unborn child, is the fact that she knows about it and then she does something about it. So at the start of the CLIP trial, we investigated the knowledge that the community women had about eclampsia and about preeclampsia. And to our surprise, we found that actually there was no word to describe eclampsia or to describe preeclampsia in the local language. So in other words, people were not aware that there is a condition called eclampsia, which is preceded by preeclampsia, which can severely affect women. So there was an awareness of hypertension, that there is such a thing as high blood pressure. Women can get high blood pressure just as men can get high blood pressure. And women can get high blood pressure when they're pregnant or when they're not pregnant. And if they get high blood pressure, they presumed that the reason for the high blood pressure was either anxiety and tension or hard work. And to them it seemed, or to they perceived, that if they had high blood pressure, the way they knew they had high blood pressure was they started feeling dizzy or they started having headaches. And if they had such a situation, they didn't have their blood pressures measured or have it checked. They would just go to the local store and buy a prescription and for headache or some other prescription, and not for high blood pressure, and they would self-medicate. So now the thing is that obviously some of the women may not have had the high blood pressure, but some of them may have had high blood pressure. So I think that was the most basic surprising finding that the CLIP trial told us, because before the start of the trial, we actually had an investigative process where we went to the healthcare facilities, the healthcare workers, the lady health workers, the women in the community, to find out what was their perception of antenatal care, what was their perception about preeclampsia and eclampsia. So I think, coming back to your point, one of the most challenging things is that, to make people understand that there is such a thing as, and the CLIP trial provided us with the opportunity to educate women. So that was a very strong component of the CLIP trial, was the component of community engagement. And this component allowed us to interact, not us directly, but the lady health workers who were working in the field, to interact directly with the women, their families, as well as the men in the community. So we had a separate community-based engagement process for the men of the community and for the women in the community, to educate them about antenatal care, about the importance of antenatal care, about the fact that hypertension can occur amongst women when they are pregnant, de novo, out of the blue, and sometimes they may have pre-existing hypertension, and that can get exacerbated. And if this happens, then these women require special care, and what kind of special care they require, and what kind of emergency services they require.
And Dr. Van Develsden, how do some of these issues that Dr. Qureshi is talking about in Pakistan, how do they compare, or how are they different than some of the issues that the investigators found and some of the site leads found in India and in Mozambique?
So the most stunning similarity was the lack of a word for preeclampsia in all three local languages. So if you're trying to discuss a concept with a community of women, many of whom have had poor or minimal education, pardon me, their partners, just to start off with, what is this condition? And to describe a concept in words that are understandable to the community, that they can relate with, that makes sense to their life experience. I mean, that was a very similar barrier.
Just out of curiosity, do the local language dictionaries now have a word for preeclampsia, or did you just bypass that entire problem and just talk about the blood pressure?
So Rahat could talk to what phrase they used in Sindh and Pakistan, but so in Mozambique they certainly introduced the word preeclampsia in Portuguese into the local lexicon, and again in India they used the word preeclampsia surrounded by a whole lot of Hindi or Kannada, which is the Karnataka language where we were working, and the So I think that did happen. We had posters up and things, and the word preeclampsia was on those posters.
Okay, continue, because I think you were going to talk about some other sort of similarities and differences amongst the three sites.
Yeah, so the status of women in all three societies is different from that experienced in the global north in terms of autonomy of decision making, the ability to have funds that they hold themselves for medical emergencies and things. So I think that was very similar between the three countries. Clearly, each of the three countries is at a different stage of development. So Northwest Karnataka in India was probably the most resilient health system with the greatest level of funding for health. a full-time ambulance service, for example, and there's a gradation of sophistication of the health system across the three countries. But what the other amazing similarity was the competence and enthusiasm of the community health workers. So the lady health workers with whom Rahat worked in Pakistan, and and each government gave us permission to work with these workforces. So the Apesh in Mozambique and the Asha workers in India, they're really intelligent, motivated, usually women. In Mozambique, the workforce was 50% men, but in the other two countries, women, who just haven't had the life opportunities that the three of us share in terms of being sent to university and having the opportunity to be educated, but they're smart and they're motivated, and this is their community and they want to get out there. And I suppose that, of the similarities between the three countries, it was that uniform enthusiasm and desire to learn and to make a difference to their communities that was shared between the three countries by the health workers.
So we're going to talk about that in a second, but let's take a quick sidebar and talk about what you and many folks who work in global health talk about as the three delays. In the UK, in the US, there's a lot of talk right now around racial inequities in maternal health, systemic racism and things like that we're dealing with as sort of an undergirding problem in maternal health. But in global health, we talk a lot about the three deadly Ds, or the three delays. Talk about what those are and how that influenced or impacted the study.
So we designed CLIP to try to overcome those delays. So the initial delay is in making understanding that I'm unwell, that there is a problem with my health status, and therefore I should begin to seek care. So it's a triage. It's a problem with triage, somebody being in the community to make a diagnosis, or you understanding enough, almost a self-triage, and say, I need to seek care. The second delay is in getting to care. So there's a delay in transport. So is the woman, does she have autonomy of decision making, or does she have to ask her husband, who might be working in a field miles away, or have to ask her mother-in-law permission to leave the home? Are there finances available? Is there a form of transport that she can tap into now, not in 4 hours or 6 hours time? So delays in transport. And then what's the road infrastructure like between where you are and where you need to seek care? And do you have to go through 3 or 4 different levels of health system before you get to the referral center where the definitive care is actually going to take place? And the final delay is once you get there, somebody has to see you, make a decision, and initiate the treatment. So there's a delay in treatment. So what we tried to do was get the triage into women's homes, so get community health workers into women's homes. We helped pilot fund some transport fees where the ambulance service didn't exist, but also just educated families about family saving for health emergencies in pregnancy. And then finally, we got permission for the community health level workers to initiate life-saving therapy in terms of methodopa for blood pressure lowering, and also administration of magnesium sulfate, which was really hard to do. And we hurt a lot of oranges practicing giving deep intramuscular injections. But yeah, I'm not sure that I would repeat that other than for very remote community health workers in the future. It was a lot of effort and took a lot of permission gathering from government to be able to do that.
So the ultimate goal of the CLIP intervention was to reduce adverse pregnancy outcomes. And when the CLIP trial was finally concluded, I remember sitting in our last steering committee meeting and getting the first look at the data from the CLIP trial, and it was disappointing. Tell us about that moment and what you learned about the primary aims of the study at that time.
So, as implemented across the three countries and in each of the three countries, and again, we have to thank the Gates Foundation and Gary Darmstadt and France Donnet, who said we will have 3 independently powered trials that we will put together at the end. And that was a huge investment by them. We, as implemented across the 3 countries, it made no difference. However, we had a problem with penetration. So in Pakistan and Mozambique, we only got to about 50% of the women in the communities that were randomized to the intervention, because there's a control group who just received care as it normally was. And in India, because the health system was functioning so well, it was hard to detect any difference, but I'll come back to that. Or you may want to with the subsequent questions. So, as implemented, we did not achieve the fidelity with the design that we'd wanted to, because we didn't mobilize a whole new raft of health workers into these communities. We used the resources that were there, because we didn't want to create a parallel Mozambique or a parallel Sindh province in Pakistan or Karnataka in India. We had to work within the resources that were available.
As we often say, work within the tensions of reality. And one of the things that global health is often criticized for is sort of introducing a temporary and unrealistic solution, unrealistic in terms of sustainability. Bringing in a bunch of resources, bringing in a solution that really doesn't have the ability to sustain itself. We even saw that back with with a lot of the magnesium sulfate trials, where it truly was a life-saving drug, but then when the trial was over, it was removed and there was no way to maintain it. So you've gone on to do further analysis of the data, leading to the most recent publication in The Lancet, what is called a meta-analysis of individual participant data. It's not a small data set. You've got close to 70,000 women in this data set. What is different about this study and this analysis from the original, shall we say, disappointing results, in that it didn't appear to reduce adverse pregnancy outcomes?
So I think the most important piece is, as we improve fidelity with the original trial design, so that the community health workers were able to provide at least 4 or 8 visits to a woman in her house, the outcomes got better. So as designed and implemented as per the protocol, in Pakistan, once women received at least 4 visits by the lady health workers, there was a statistically significant and clinically important reduction in adverse maternal events, adverse fetal events in terms of stillbirth, and decreases in neonatal mortality. In India and in Mozambique, that didn't happen until we got out to at least 8 visits. So overall in the meta-analysis, the sweet point is 8 visits, which interestingly is the new WHO recommendation for the number of contacts provided to a woman in a pregnancy anywhere on the planet. So by chance, we happen to have reinforced their guidance, and we're talking about a measured reduction in maternal death, and that doesn't happen often. Unfortunately, that meant that in the control groups and in areas where there wasn't access to the lady health workers or the outpatient or the ASHA workers, women died. Women in their teens, their 20s and their 30s died. And we now know that maybe that needn't have happened. And there was a reduction in stillbirths, and there was a reduction in newborn deaths, but at a price of more babies being sick, but surviving their newborn illness. So we paid a bit of a price in terms of buying into some children who were sicker than they might otherwise have been, but they survived more often.
Mm-hmm.
So that's where we're at.
Dr. Qureshi, talk a little bit about, so that was at the meta-analysis level. How did those results mirror your experience in Pakistan, or not mirror?
So I think I would agree with Peter about the challenges in terms of reaching out and making the inroads and reaching out to only 50% of the population that we intended in Pakistan. And this was because we were using the lady health workers, who are actually government workers and who are working on an ongoing basis within the community. And because the number of lady health workers that we have for any particular community, we don't have the optimum numbers. And so we don't have that optimum reach in the community. And this we understood even more significantly when we were doing the CLIP trial. So I think as far as the outcomes are concerned, we found that that for women who were not really having any kind of visits, antenatal visits in the community, we found that these women were now having antenatal visits, proper antenatal visits where the blood pressures were being checked. And so as the numbers of the antenatal visits started to increase, the number of interactions of the women with the community, with the lady health workers was increasing. And as that was increasing, the level of education of the women was increasing. The level of education of the family members was increasing, and they were engaging more with the pregnancy and getting more and more involved with the pregnancy and the pregnancy outcome. So this is certainly a very important feature that we discovered in a country where we have very high perinatal mortality, where we have a very high stillbirth rate. We found that the stillbirth rate in the women who did interact with the CLIP workers, with the lady health workers, there we found an important decrease in the stillbirth rate, and we found an improvement in the perinatal morbidity and mortality rate. So, so this was, for us, this was indeed a very significant outcome, and I think it is a pointer for other kind of interventions which we can use to decrease our stillbirth rate, which is one of the highest in the world in Pakistan.
What did you learn from the mothers themselves?
So I think as far as the mothers themselves are concerned, it was a package that we understood. It was not just the woman herself, but where she was living, her environment, which was contributing to what she could do and what she could not do. So I think on the whole, we found that the environment was not hostile. It was not a negative environment in terms of stopping the woman from getting care, but the environment was more of a kind of where people really didn't know exactly what was the benefit. And also, I think there was a lack of planning. That's what we found in our project, that there was a lack of planning in terms of talking about a situation where the woman might need help and what she should do in that situation, who she should go to, where she should go to, who would provide the finances, who would arrange the transport, how would the transport be arranged. So these were the very significant, and I think one of the important things that we did, and one of the important the legacies that CLIP has left behind with the communities is that we realizing that there was no organized transport system in many remote villages. We would go to the local stop, the transport stop, and get the telephone numbers of the private transport workers who were working there, and give them to the significant members of the community, so that if they ever needed help in the evening time when there is no transport at all, they could use those numbers. And mobile phones are very easily available and used, I think, in Pakistan and all over the world now. So that was one of the legacies we left behind, where we left behind this concept that if you don't have an organized transport system to carry women to the hospital whenever they need help, then they can mobilize their resources locally to try to have a support system when they need the help.
So, Dr. van Dedelzen, I think one of the things that's most remarkable about the CLIP trial and more largely the whole preempt package is just the amount of investment in the topic of preeclampsia on a global scale. I think this is unheard of, quite frankly. We follow the space very closely, and we know that there are very few research studies specifically talking about preeclampsia. I think you and I both recall being at Women Deliver in 2010 and literally being on the only panel talking about preeclampsia in an agenda of over 200 talks, which of course is quite concerning to us. But I do think that, you know, I guess the question is this: what does the work that you've done here suggest about the future of preeclampsia and what we need to be doing on a global basis? Because we do know that, you know, as much as we fight to improve the conditions in our high-income countries, the problem is infinitely worse in low and middle-income countries. So where do we need to be focusing our attention if we are going to reduce this burden on mothers and their babies?
Thanks, Eleni. I mean, that really is probably it's a $60 million question. So what we learned from CLIP is that just targeting the community isn't enough. But what we did achieve in CLIP is we better integrated, I think, and again, Rahat can reflect on the Pakistan experience, but we better integrated the lady health workers in Pakistan, let's say, with the health system. Their status was improved. Because they were carrying these devices, they had digital health apps that helped guide their decision making, that took them through an antenatal visit, so they didn't have to learn it all. They just had to follow paradigms and pathways. That was a success. But where we need to go is an integrated approach that looks at women, not at necessarily just magnesium sulfate for eclampsia treatment or prevention or antihypertensives. I mean, these are women who live their lives and need support across the board and through a vertically integrated health system that can learn. So where I think we need to go is to come up with digital health toolkits that provide an electronic health record that can be shared between levels of the health system, that has embedded decision algorithms in it, such as we had in the CLIP trials, but also helps the health worker. Because if you're a health worker in a primary health center in Pakistan, you're probably going to spend 4 or 5 hours a week filling out forms to send to the district health officer about the number of antenatal visits, the number of births, the number of stillbirths, all the things that have happened, and you may never see those data back again. Whereas if you do it digitally, and that reporting occurs spontaneously out of the back end of a digital platform, because if a woman's got hypertension and proteinuria, she has preeclampsia, so you can tick another one of those cases in the preeclampsia box, rather than having to review all the files, then that health worker can see how they're performing, what their outcomes are like, but they can also look at the other primary health centers nearby and the regional referral center, and they can actually see what happened to the woman they sent. So there's an ability to learn and create a learning health system that that is mutually supported from top to bottom. I think we largely know what to do. We need to know the nuances around, are some drugs better in some settings than others? Women in sub-Saharan Africa are likely to be relatively resistant to labetalol. So should we be pushing labetalol in Africa? Probably not. Whereas in Pakistan, it's almost certainly a really good solution. So we have to be nuanced, but we need to be better at pulling it together. I think we know enough now, and then we can feed new knowledge into that core framework to provide care.
And certainly the most recent analysis underscored the need for more community health workers
Yes.
That was probably the biggest takeaway from the most recent publication. So to the extent that that governments or policy or the economic engine can support that profession, if you will, that certainly would be part of this integrated package. I think it underscores the problem with most health conditions, and that is that there really is no one simple fix, right? This is not the magic pill that we're looking for that's going to solve all the problems that we need to be hitting on all fronts. Dr. Qureshi, what's the, I'll give you the final word as we close out here, but what is the takeaway that you might be trying to implement across Pakistan or within the communities where the trial has been conducted? Is there any residual impact or effect that you're driving toward?
So, so Peter just talked about electronic health systems, integrated systems, getting information across, you're finding out who's at risk, getting them help much earlier. So these are the kind of innovative ideas that can come in, and they can certainly improve systems and they can improve outcomes. But apart from that, I think there's a tremendous need and for a drive for improving the awareness and the education of the ordinary people as well as in the health facilities about the disease itself and how to deal with it. So one of the things that has happened since the trial is that the lady health worker manual, their curriculum has been updated. It hadn't been updated for the last 15 years. So it's been updated so that all the important aspects regarding the findings from CLIP and regarding medical evidence-based management and intervention can be incorporated. So the Lady Health Worker program themselves asked the Aga Khan University to actually do this for them. And we spent about 6 months working on the curriculum and improving the curriculum and improving the way that the curriculum is delivered. So I think that's a very positive step in the direction of integrating public health workers, community workers into working for the health of women in the community. And also it has a very strong component of working for the health of newborn babies and of children. So Aga Khan Hospital is actually working at different levels and working at hospital level as well as academic level to try to improve the capacity. And so we talked about the 3 delays. And one of the tragedies is that when a woman reaches the health center, that she's unable to get the help that she actually requires because the people who are receiving them, the healthcare providers who are receiving them may not have the drugs available or may not have all the protocols in place to be able to institute those immediately to be able to give the best possible outcome for the mother. So I think these are the things that we've started working. We were already working on these before, but now the CLIP trial has actually increased the awareness of different levels of healthcare providers about the importance of these interventions, how they can actually improve outcomes. So this is where we are working, and I think one of our other investigators, Dr. Bhutta, is also working with the government to try to implement policies and try to develop policies which can help implement some of the ideas and some of the thoughts and some of the principles that we have gathered from our work with the community level. So I think that we still have a long way to go, and we have a lot of things that we have to implement at different levels. And I'm very hopeful that we will continue with this partnership with the government, with our investigators, with Peter, with the UBC, and we will continue this partnership to keep on improving the health of women in countries like Pakistan.
Thank you so much. This has been a wonderful talk, and I think you both have done a wonderful job of outlining where the work, the advocacy work still needs to happen to change the direction of global health, specifically for preeclampsia. Today we have been talking about the publication that came out recently in the Lancet, the community level interventions for preeclampsia, the CLIP trial, and looking at some of the aggregate findings from that trial and how it might change, how it could open our eyes to what we need to do to improve outcomes in preeclampsia around the world. So thank you so much to Peter Van Dedelzen and Rahat Qureshi, who have been instrumental. Dr. Van Dedelzen, of course, was the PI overseeing the entire package, and Dr. Qureshi in Pakistan was the principal investigator there. So thank you both for spending time with us talking about global health and preeclampsia. Have a wonderful day.